afternoon. My name is Mitzi Keys Glass, and I am a licensed clinical social worker and board member of the ARDX Foundation. At the ARDX Foundation, our goal is to shine a light on the importance of mental and behavioral wellness and serve as an advocate, partner, educators, mentors, and change agents. We believe in improving the health and well-being of our most vulnerable populations, including women, youth, and the elderly in disadvantaged communities. Each year in July, the ARDX Foundation takes the time to recognize Minority Mental Health Awareness Month. Since 2008, thanks to B.B. Moore Campbell, noted author and mental health advocate, July has been designated as a time to think about mental health in diverse communities, stigma, and the disparities associated with receiving help. Most importantly, it is an opportunity to think about how we can move the needle in regards to diverse communities and mental health. The 2023 theme is communities, connections, and culture. Today, I have with me 4 esteemed experts who will share their perspectives concerning minority mental health. It is an honor to have them join us today for this very important discussion. Dr. Brittny Gainey, LCSW, is from Hampton City Schools. Her colleague, Lawrence Holloway, is a resident in counseling and is also from Hampton City Schools. Dr. LaConda Fanning is a LPC and provides leadership in the area of justice, diversity, equity, and inclusion at Eastern Virginia Medical School. Dr. Nedra Moncrief-Craig is the Systems Director of Behavioral Health Services for Sentara Healthcare and has a special interest in mental health in minority geriatric communities. Today, we want to discuss minority mental health in children and adolescents, the community, families, and the elderly. We hope to address systemic issues, including stigma, disparities, racism, and so much more. Most importantly, our panelists will discuss ways that the issues of minority mental health can be addressed by clinicians, our faith community, our social organizations, the community, and you. So let's get on with our discussion. And again, I thank you for those who are with us today listening to our discussion. So let's lay the groundwork. And let's start off with, what do you all think is the understanding of minority mental health in minority communities? I'd like to start at the beginning with Dr. Brittny Gainey.
All right. Hello to our esteemed panel again. I'm so excited to be with you all to have such a robust conversation. So one thing I would just like to put out there, October 19th, 2021, the American Academy of Pediatrics and the Children's Hospital Association administered a state of emergency for child and adolescent mental health. And this was in response to children and adolescents' reactions to the COVID-19 pandemic. And so the state of emergency highlighted some things such as anxiety, depression, thoughts of suicide, but it also talked about our minority populations dealing with things such as social injustice. It talked about our experiences with grief and loss. And so I think this state of emergency was so pertinent because usually when we think about mental health, we think about things like ADHD, we think about depression, we think about anxiety. However, this was another highlight within our community in particular. We're dealing with some other things like thoughts of suicide. We're dealing with things like grief and loss. We're dealing with things like systemic racism and how those things are impacting how we cope every day, how we cope, how we think, how we act, how we feel. And so within our community, I think we have to look at things outside of just those normal day-to-day mental health experiences that people like to talk about and highlight.
Yeah, Thank you. Thank you. So it started with children. Thank you. What about the communities and families? Dr. Fanning, what do you think?
I would definitely think that there's been a major shift in what we believe, and that has increased what I think are the gaps in the understanding for Black families. First, just when we say mental illness, or even we have to be clear that we're talking about not just like Dr. Gainey mentioned, the diagnosable ones, the pathology that you hear, the ADHD, the bipolar, the depression, but we are talking in a space right now where extreme anger, pathological anger, and responses to anger. This morning, coming in on the news, it was a person who had shot and killed their physician, their surgeon, this morning. And then it was the sentencing of two young men, twins in Hampton, that was sentenced today because of, again, shooting a young woman and her child. So I think that things that typically were issues, but they're just now at the forefront because of what we've just come out of. The anger is pathological, and we typically won't see it that way. And how we respond and the misperceptions has created this overwhelming trauma that's there that we have to talk about a little bit even more. And I think it has extremely disrupted the fiber and the fabric of the family. And so it's put us in a space that we have to have mental health as a part of the conversation, not mental illness, but just mental health and mental wellness. So that again, I think is something that as a family, we're very challenged about, because it's something we didn't talk about before COVID.
Yeah.
Right. And there was a lot of trust and hurt and distrust in our community prior to COVID. And so now it's just essential that we help just kind of communicate and provide a different level of skill set to having those conversations, because we're in a survival mode right now.
Wow. Thank you, Dr. Fanning. Are you seeing the same thing, Mr. Holloway? Or what are you seeing?
I would agree. Thinking about the comments from Dr. Gainey and Dr. Fanning, I was thinking about how both of those things are true, but the challenge I've seen is what the pandemic highlighted for us is not only are these things existing, but we are in critical need in terms of how we support them. A lot of our children, youth, and even our families are experiencing some difficulties, and the resources that they need to address them are scarce, whether it's either for families who are actively seeking qualified mental health treatment, or even those who just want someone to say, hey, I'm struggling, I have some people in my family that are struggling, and we need some help. And being able to find that help has been extremely difficult for a number of reasons. Of course, during the pandemic, it was because of the social protocols that we all were, utilizing and that sort of thing. But just also not being able to know, or not knowing where those resources are in our communities and how to access them, and how to utilize our familiar organizations. So we may not know where the therapist is, we know where our church is, and does our church know how to get us to a therapist and that type of thing.
Yeah, thank you. Thank you. For our audience, we're talking about laying the groundwork. So Dr. Moncrief-Craig, you really helped me with a layer of understanding that, to be honest, I had not really thought about until you and I had the opportunity to share, and that's mental health in our elderly geriatric minority population. Can you lay some groundwork for us in terms of helping us to understand that? You're on mute, Doctor.
There's about 4.8 million African Americans that are elderly that experience some type of mental health, but there are only about 20% of them that actually receive the services that they need for their mental health. And one of the things that we found out is that oftentimes as somebody ages, people look at them differently. Like they don't know what they're talking about, they don't understand what's going on and stuff. So I think one of the big barriers for the geriatric population is people understanding them, understanding their culture, understanding their beliefs. and stuff. And they've grown up, a lot of them have grown up not to believe in seeking therapy, not to believe in, going to the doctor to talk about your mental health. There's a lot of privacy in, the African-American culture. We don't tell our business outside of our family. So, breaking down those issues and people sitting and actually listening to them and trying to understand what's going on with them instead of them pushing their beliefs onto them.
Wow.
Yeah, that's a big problem when you talk about geriatrics, is oftentimes we think, as professionals, we know best and stuff, and we don't. We do not understand some of the things that they've gone throughout life, and some of the things that might be hindering them from getting the services they need. The social determinants of health is a major hindrance for the geriatric population, or we call them now the older adults. And so, because it's a major hindrance. These individuals live on fixed incomes and they can't afford some of the medications. They don't have the transportation. They are living in food deserts and stuff. So you have to choose with them. They're having to choose between medication and being able to have a place to stay. Wow. And oftentimes, you have to throw in that family dynamics. Some of them are taking care of their grandkids and stuff. So, it makes it even harder. So like Lawrence said, Ms. Holloway came to a good point. That's where that community and that faith base comes in at. Because, if we can educate them on mental illness, first aid mental health, teach them the signs, teach them how to get people help, give them the resources, oftentimes they have a big influence on people seeking help.
Yeah, thank you. And you all are really speaking to the theme, which is communities, connection, and culture. So thank you for the groundwork. So let's move to some more specifics now. Dr. Gainey and Mr. Holloway, can you talk about, from your vantage point, what are some of the specific community challenges that, starting with our youth, are experiencing that impact their mental health? And I know you all see it from the schools, but also, you intersect with communities. Can you all speak to that a little bit for me?
You're gonna go first, Lauren, so I can get it started.
Sure, it looked like you were about to speak. I'm sorry. So I think in my context, the biggest challenge that I see is gun violence. And so, and the interesting thing is gun violence isn't new. I know it's a topic in the news as if, now we need to do something about it. It really is a public health issue. But gun violence in the community, especially in minority communities, has always been there, at least for the last 30 or 40 years. But it is different because gun violence today is youth. Like a lot of the things you see on the news and the people that are losing their lives are people who have not made it to the age of 16 yet. So I think that's causing people to recognize that maybe we do have a problem, because these are young people who have not had the opportunity to be afforded to experience life. And it really has a ripple effect, because it's not just the individual children who are being shot or being murdered, but it is their friends. So it is their peers in school who have to come back to school and it was like, hey, such and such was here on Tuesday, Wednesday they're not here, and we have to go to school and deal with the fact that, my friend isn't here and I miss him. And it moves beyond that. It's their families, but it's the community as well, because the community has a responsibility to respond and to support. And I think now a lot of people are finding themselves challenged on how we do that. How do we respond? How do we support? And I know here in Hampton, we have some great individuals who are kind of taking it upon themselves to kind of step up and try to fill the gaps. But I think as a community, not just in Hampton, but in general, we have a responsibility to come together in a coordinated way to respond to these challenges, because our young people deserve opportunities to grow up, live, and experience life on their terms.
Yeah, thank you for talking about the gun violence. We could do a discussion just on gun violence in our communities. I mean, it's huge. Dr. Gainey, are you noticing some, in addition to the gun violence, some other community challenges that is impacting minority youth and their mental health?
Absolutely. And I also want to kind of respond to some of the things that Mr. Holloway said as well. I think the challenge with the gun violence is it's traumatizing, right? And so it's traumatizing to those individuals who were involved, but it's also traumatizing to that community. And what makes it worse is sometimes they don't have the coping skills to deal with that particular trauma. One, because it may be because of access, but two, some things are so normalized in our community. So a lot of our kids, they may talk about what has happened at home in their neighborhood, and their friend is going to say the same thing is going on. And so I may say, I haven't had that experience, and so I'm an anomaly, right? Because everyone else is experiencing this, and so it's something that's normal and that they're used to, as opposed to saying, this is not okay. You have the capacity to handle situations using your words. You don't always have to resort to these other means. And so I think that's, definitely one of our community challenges, because where do our children and adolescents go when the adults in their life may be responding in the same manner?
Yeah, thank you for that. So gun violence is a huge issue with our children and our adolescents that's having a ripple effect. And definitely I could hear the trauma. Dr. Fanning, what are some of those challenges that our families and communities are experiencing? I know you spoke to it a little bit when you were laying the groundwork, but what are some of those other challenges that is affecting, impacting minority mental health in our communities and within our families?
Yeah, I think, they definitely touched on some of the main issues with the children and the families, but one of the significant things that is intergenerational trauma. It didn't just start with the gun violence today or yesterday, and I think that's something, again, that kind of permeates our foundation, is not, again, and recognizing that this is something that has been perpetuated over in generation to generation. And we're in a space where we have to own that we need additional support and resources. 1 out of every 2 of our minority families is the household is ran by a woman. That's okay, but it highlights the burden of the single parent. Right now, another complex issue is the financial impact, or having both of the families have to be work outside the home. And right now, you need most families work. One of the spouses, or if you have a 2-parent home, one of them work 2 jobs, right? And so the issue of who is connecting and doing the teaching and the nursing and the mentoring and the follow-up of the children, it's a very, very critical space that we're in. And like Lawrence had mentioned, when you seek outside for support, if you have enough courage to even ask, because with the same intergenerational trauma is a major component of guilt and shame and secrecy that has also been perpetuated, which it kind of makes it complex the issue, right? Okay, and so it's very important to know and try to normalize that, hey, we recognize that we all have trauma. We all have intergenerational things that have influenced how we speak, how we teach, how we nurse, and how we seek help. And so, but being able to not identify those, and not want to put another label on something that's already heavy and overwhelming within your family, it's tough, especially with minority children, and you don't want to mislabel them. And I'm a big one, trained as a psychologist, to not overdiagnose my kids. And so trauma looks like ADHD. It looks like
yes, it does.
It looks like, and if we don't address just that, then it becomes a major issue. And so not just teaching the family, but also supporting the professional in that, to provide the right type of support. So those are just a couple of the issues, but they're huge. And so they put us in a space where we're trying to make it, we're trying to survive, but there's a lack of trust. There's a lack of support, there's a lack of resources. And so sometimes you're just overwhelmed to just even acknowledge what are all of these extra things outside of your family, just for you to be able to sit down and have a conversation about it.
Yeah. It's interesting you talked about the intergenerational trauma. So I often say that parents are trying to parent through their trauma.
Absolutely.
They're trying to parent through their trauma. And so then what happens is you take that trauma from one generation to the next, all the way up to, as Erickson says, that last developmental place in the life cycle, integrity versus despair. And so that's you, Dr. Moncrief-Craig. You know, you've got folks who are elderly who have not worked out their trauma.
Yeah, and so that has
I get, yeah. Can you talk to that a little bit?
Yes. So, and it affects the elderly because, they've lived through a lot. It didn't stop at 16. It continued on to they're like 85, 90. And some of them are in nursing homes today and are suffering from, traumatic experiences and people not understanding that, they didn't talk about it. So how do you get them to a point where they'll talk about what's been going on in their lives and get them to a good point and stuff where they're taking medications like they need to take and stuff, and the behaviors are subdued some, because a lot of them do have those behaviors that they respond to. I've taken care of mental health individuals in state hospitals that were there because all the traumatic things that happened when they were in the military or it happened in their life and stuff, they couldn't deal with it. So they ended up in an institution and, into their 80s and 90s. I even had a patient 100 and stuff and could not be lived in society because they couldn't cope with it. We even discharged them, try to get them integrated back in and stuff, but it was just the trauma. They got to see so much more traumatic experiences when they watching the news and stuff. It triggers. That's why we tell people, don't watch the news. That's not good for you, and stuff, limit your news and stuff. Limit some of that family involvement where families have actually taken advantage of the elderly people, financially. They have exploited them, have abused mom and dad, being abusive to them, beating them, and stuff. And then them seeing the kids, the grandkids being abused, them trying, and even the sexual trauma that comes along with that. We've had elderly people who have been actually raped at the age of 65 by younger family members. Wow. And so, it's all that traumatic experiences that they actually take in and they never get help for it. And then once they get older, you'll start seeing those behaviors and them actually acting out, and some of them do become violent. So, trying to limit some of the traumatic experiences someone has when they're young, just like Lawrence and Dr. Brittny was saying, is great, because hopefully, that way they don't grow up and have those experiences and then exhibiting those bad behaviors at an older age. So, yeah, so that's important.
Yeah. Thank you. So many layers.
Yeah, it is. And it affects you from childhood up. Yeah. And that's what people don't realize. Mental health affects you from youth on up to adult to older age. It's every part of your life. So actually, let's get help now so it won't affect you as you grow older.
I love that. I saw you unmute, Dr. Gainey.
Yeah, I was going to say, and I think when we talk about trauma, we have to broaden our lens, so a lot of times people think about trauma as far as things that happen directly. So that emotional abuse, that sexual abuse, that physical abuse. But when we look at it from like the Philadelphia ACEs point of view, we look at poverty, we look at bullying, we look at discrimination. We look at the quality of housing. And so those things can produce toxic stress. They can create traumatic experiences. And so as practitioners, as educators, as those who are interacting, with our minority population, we have to make sure that we are looking at those things as well, so we don't limit the lived experiences of those we're trying to serve and support.
Yeah. Thank you for that.
Something as well.
Sure.
I appreciate Dr. Gainey for saying that, because I think that connects across the spectrum, because when we talk about like the Philadelphia ACEs in terms of children, that connects to the healthcare setting, because those are the same things we're talking about when we're talking about social determinants of health. And so it helps us to see that all of those things are working together, and not one for children is something completely different for adults. It's the same thing across the lifespan that we need to consider. So it kind of connects to with Dr. Moncrief-Craig is saying, because when we're talking about older adults, they have some ACEs as well if they sit down and go back to their childhood. And so we're talking about the trauma that they've experienced. Do we ever consider what would ACEs look like for an 85-year-old woman?
Wow. Mr.
That would
Holloway,
help
that's
us.
good. That's
Yeah,
good.
that's good.
That's good
It may help
stuff.
to inform. It will help to inform their life experiences, because
Wow.
when they go back and reflect over maybe their adulthood, they can say, well, you know what? I never considered that these experiences in my childhood impacted me in this way, that I made certain
Yes.
decisions in adulthood that have kind of led me to where I am now. And I say that because in interacting with older adults in the way I do, I find that for certain generations, particularly boomers and beyond, they don't always recognize that those types of things that Dr. Gainey is talking about in the Philadelphia ACEs are influences in their life.
Yeah.
If I talk to a 65-year-old woman who grew up in poverty, she may not tell me that her growing up in poverty and not having much food or clothes and things that they needed was traumatic to them. They would tell you that it is life, we dealt with it, we did the best that we could, and we moved forward. But it does not negate the fact that it probably still has an impact on your life. And so how do we address that now, because you're in a different stage of life, and being mindful of our stages? What does all that mean for you, and how can we support you moving forward?
Yeah.
Yeah,
Thank
and
you.
and
I had
what
never
Mr.
thought
Lawrence,
about that.
yeah, and what Mr. Holloway just said is true. As they get older and stuff, for instance, people who grew up in poverty, and once they get older, if you hadn't noticed, they start hoarding. They start holding on to stuff, because guess what? They don't know when they're going to get food again and stuff. We see that all the time, especially when they start getting dementia and Alzheimer's. They're hoarding, they're hiding stuff. But, people are thinking they're hiding because they don't know when they're going to get it again.
Yes.
And I actually had some clients, because I'm from the great state of Alabama and stuff. So I had some clients who actually were in the Tuskegee study and stuff. So anything that had to do with us saying you need to get your flu shot, you need to get this done and stuff, they went back to that traumatic time, and they would resist and stuff, getting their shots and everything. And even in the South now, people, when the COVID started coming, if you would notice, the numbers of people getting vaccinated in the South was low, because of that historical trauma that, that culture felt, the Black culture actually experienced from those studies and stuff. So yeah, it plays out throughout your life and stuff. So yeah, Mr. Holloway's right. Only if people realize what you're taking into your older age with you.
Yeah.
I just want to add to that it's so important to meet people where they are, especially seniors. And the more, we cannot minimize how much. A good example was what Nedra mentioned was those shots in COVID. You cannot believe that they're just going to be open to another shot. And even now, there's still a major significant level of distrust. And if we struggle with it as healthcare providers, if we're honest, especially now being on the 4th or 5th shot, we have our own concerns. And so just imagine when you've had to be a part of the lived experience, and then what we're asking you to do. Right. And so that's extremely important. And I think we have to recognize the trauma is about resilience and normalizing some of the things that they've been through. And I think it's fascinating, Lawrence, just to think about a senior, because all of the ACE, all of the criteria would be checked. Right. And so it may or may not look like it holds relevance, but it's very relevant to how much a person has been through with that life and the level of resilience and wisdom that they have, but we have to connect with them a different way. Yeah, and appreciate them a different way, and so that's so important, even of how we even define mental illness or mental health, and just those words can be very, very much off-putting to them when they've had to come through and build their own resilience. And part of the whole journey is to be normal, to come out of it, to have to deal with things, and you got to get over it and keep moving. You keep moving regardless, and we still have some of that in us today, to keep moving. And so that's part of our strength, but it's also part of our part of how we hinder ourselves.
I thank you for that. And don't you wish that, as I'm thinking about minority communities and under-resourced communities, that when they went through different systems, so for instance, the healthcare system, that more people, and Mr. Holloway, this really makes me think about, that we ask the trauma question, not what's wrong with you, but what happened to you, and to really think about from a historical trauma perspective as well as a generational trauma perspective. And I'm not sure that our practitioners who are not from minority experiences really understand that. So
that's a weekend bar.
Say that again. Oh, I'm sorry. So I'm not, so as you're talking, it makes me think about asking, our communities, not what's wrong with you, but what happened to you. But again, if you don't understand trauma from a minority, I love that word, lived experiences, you won't know that. So then our behavior becomes pathologized.
Absolutely.
Our behavior becomes
pathologized.
And Missy, just like we always talk about peer support specialists have that lived experience and stuff, you need those people who have lived experience to work with each age group, because you don't understand them until you've actually lived like they have or went through some of the things they've gone through. So I think that's important, not just peer support specialists for adults, but in children and adolescents and geriatrics, it is so important to have somebody who actually can relate to what you're talking about, who understand what you're going through, and who can help you navigate the system. So I think that's important.
Yeah, and I want to add, I remember at the beginning of the conversation, we were talking about how our older adults a lot of times are taking care of our children and our adolescents. And so, and also connecting that thing about parenting through a lens of trauma. And so sometimes we feel like, okay, some parents, they don't want to get their children support, or, hey, you have all these options and opportunities, however, you're standing in your own way, but we're not really considering what things were like back then. And so you're asking me to go into these majority spaces. However, back in my day, things were separate. And so now you're expecting me just to kind of enter at will, but that's not how things have been. And so it's not that I don't want to get my grandchild support. I'm still dealing with the thought process of, if this didn't say colors only, then we don't go in there, and so we have to really normalize that, because that's real, or I know for us, a lot of times we work with students who are identified as McKinney-Vento, meaning that they're homeless. And so we may have a family say, hey, it's 25 of you all living in a home. Do you want to fill out this paperwork to say that, you're McKinney-Vento, you can get support? No, because back in the day, that's what we did. That was community. We're not going to let someone live out on the street. We're going to all be together. But I'm telling you, if you help me and you can fill this out, we can get, but no. That's not how my lived experiences have.
Wow, that's good. That's
good. So it's not that I don't want to get the support and the resources based on what my history is. This may not work for me right now.
Everything that we define as help is not help. That was a great lesson that I learned. I might define it as help, but it's not necessarily really help. So we have to change how we think about what help is.
Can I add something real quick?
Sure.
when you say that, because I agree, and it's the approach that I try to have, because I really think that when we ask that trauma question of what happened to you, I think people's story inform our helping ability. And so when, for example, in schools, we often talk about behavior as communication, right? So when we try to address behavior with a student, it's often because the behavior is communicating something about an unmet need or something of that nature. But I think the same thing is true for other people as well. So even in adulthood, because it's not necessarily a tantrum and we're falling out on the floor, certain behaviors are informed by our history and what happened to us. And so when our behavior is informed by what happened to us, then we have to sit down and consider what does help look like? Because like you said, I can say, okay, this is what you need, but for that person, that is not what they need because they don't consider what I consider to be a problem, or they don't see that help as necessary. So then I have to take a step back as a practitioner and say, okay, when I ask you, I try not to ask people, how can I help you or what do you need help with? I try to ask them, how can I support you?
Wow, that's good.
Support, number one, help has become a stigmatized word in itself. And even I have students now that say, I don't like that word. Like, I don't want you to ask me that.
Thank you for
When
that.
you say that, that makes me feel like I am deficient.
That's good. That's good.
So how can I support you? Meaning, whatever you have going on, what do you identify? It gives you the autonomy and it gives you the driving force to say, this is what I identify as my need right now, and this is what you can do to support me. It gives the person their own, it gives them more control because it takes me out of the leadership role and saying, this is what we're going to do for you as a helping professional. No, you get to decide as a patient or the client or the whoever, what you need and how we're going to help you. And then we're going to move together, working hand in hand, not provider leading the patient.
That's good. And Lawrence and Mr. Holloway, that's a good segue into addressing stigma and systems issues. You all have spoken to it a little bit, but racism and stigma and the barriers to seeking treatment. Does anyone want to start off that discussion? What are some of the systemic issues that affect our communities, minority communities, in terms of seeking help for not mental illness, but mental health challenges? I try not to use the word mental illness because mental illness doesn't come from a place of strength. It comes from a place of deficit, and pathology. But what are your thoughts? Barriers.
Well, one of the barriers that we see is the lack of diversity in the actual mental health providers.
Yes.
And there's not enough people that look like the person who's seeking services. And so a lot of people are like, no, I'm not going to that person. They don't understand me. And then a lot of it is that the diagnosis that they give somebody that is a minority is usually the worst diagnosis. But the other person and I have the same behaviors, but you give them something less in the DSM-5, like schizophrenia. You hear that all the time in the African-American community and stuff, so some of it is people being misdiagnosed, the lack of people that look like them who are providing the services, the lack of understanding and stuff, and then the lack of resources in their community. They actually having to travel outside of their community to go get services. And even when you go probably 30 minutes to 45 minutes an hour, you still don't see that diversity with that healthcare person. So that's a huge barrier. And then there's still the issue of, we don't trust you.
Mm-hmm.
And so, and if I tell you what's going on with me, you're going to put it in that record. Everybody's going to know what you put in that record. They're going to look at me different. So that stigma still hasn't gone away.
Thank you. And anybody else want to speak to some of the barriers?
Yeah, I just to add to that, from not having representation within the discipline, so there's not enough people that not just look like us, but that we can feel are relatable, right? And so we want you to be relatable to my situation, or can be compassionate to my issue, right? And so it's difficult, even when you're a non-minority, if you don't know any historical information about African Americans. I am amazed with all of the injustices that we've continued to come through now. I had one of the clinicians was so frustrated one day, he just said, does anybody read a book? Right? Why am I telling you about the Tuskegee experiment or the syphilis experiment? Why do I have to educate you about the underpinnings of why we don't trust? That I'm just floored by that. And so it's frustrating to always not have a person there when you need care that you feel like really doesn't understand your journey, because you are a minority and you're always put into place to have to explain that story. That is extremely it's not a fair burden to place on the minority or a person that's needing services. Right? Why do I have to be diagnosed, which is part of the reasons I went into mental health was because of what Nedra mentioned, because of seeing so many minorities misdiagnosed with schizophrenia, or just the extreme mislabeling, or my symptomology is heightened. Right? Instead of owning, I don't know enough. I don't know what this looks like. I tell anyone, depression in an adolescent is never going to look like them overwhelmed, sitting in the corner crying all the time, right? But it might look like I'm gonna give you 3 warnings, and then I might have to hit you, right? And so because I have told you, it might look like me just shutting down or becoming argumentative. And so, but why do I have to always have that burden? It just feels like another burden on that minority. And that's a systemic problem. That's a systemic barrier. It's the lack of accountability of taking responsibility as a practitioner to learn the people that you serve.
Thank you.
Right? And that's very, very important. And so it's always the minority client have to know so much. Right? You're trying to find support. You're in need of help. You're looking for your support for your family and your children. And you already have internal issues, but it's systematic issues of not being able to find a person that can relate to you, having to explain why you're here, what's going on. And remember, it's already a shameful piece. So you need someone that's going to be able to understand, to give you that level of compassion when you decide to take a risk. So access to care, access to the right practitioner, and then the financial barrier. Mental health is extremely expensive. Yeah, it's extremely expensive. And so even when we want you to continue to receive services, even though there's some resources, there's a lot of people who cannot afford, especially if I look at students. They can't afford to get support and service. Children should not, there's some support, but no children should be paying for services. And then when they're 18 and they're students, we give a diagnosis, especially with schizophrenia, that the main chronological age of diagnosis is 18 to 24. With Black males, but it's that group of kids that have the least amount of resources. And so they're considered grown and they're not, right? And so what do you do? So they continue to have to deal with that oppression and those systemic barriers and try to navigate these systems by themselves. And sometimes when a resource is not there, then the time or the person to advocate and support them is also not there, and so that's a big deal.
Thank you. Wow, you all have, I tell you, I'm feeling a little convicted here. I'm learning, but also, but we're learning and really having to pivot even in our own practice, so not just for our audience, but even in our own practice. So we have a few more minutes left. I want, as we close, what can we do? We each of us on this call, we're clinicians, we're involved in our faith communities, we're involved in social and service organizations, we serve on boards, we're embedded in our community in different ways. for our audience who's listening to this and who's saying, what can I do to move the needle? I would really like for each of you all to kind of take a minute and really talk about what we can do. The discussion is great. I love it, but we really want to move the needle. We really want to empower people that they can make a difference. Brittny?
Yeah, I want to just say to the practitioner first, a minority practitioner, especially, is recognize that your expertise or your profession is a call. Not something that it just came out that you have this interest. So recognize your purpose and your call. Because you have to, because your minority tax is a part of the call. Recognize it's going to be a tax. You are chosen to be put in situations to have a voice, to advocate for people of color, especially with mental illness. When I started at Christian Psychotherapy years and years ago, and when I was at Sentara for 20 years, I was always the only minority. Right, always the only minority. And so you have to have your own well-care plan for yourself, so you can also, and just kind of own it's okay to be that. But you will be used to open up doors for other practitioners.
Yes.
And so don't get discouraged this journey, in helping mental health, because it is a part of what we do. And so we have to own that. So we can keep our network and support one another. But change is occurring. And I always say, a step is a step. I don't care how much of a baby step it is. A step is a step, right? And so, and just be encouraged in that. And that's because if we are frustrated, that's also what our patients will see.
Wow, that's good. That's good. That's good. I love that call. It's just sometimes Dr. Gainey says to me, "Ma, do you ever let it go?" And I said, I can't. I mean, I see I'm a licensed clinical social worker. I'm a social worker at my core, and that's how I see the world, unashamedly, fighting every day for social justice for people who look like me.
Yes.
So, Dr. Gainey, what can we do? What can our audience do?
So I think one thing that we can definitely do is to own your story, but also don't be ashamed to share your story. And
that's good. That's good.
I think oftentimes people kind of write our story for us, right? Even as practitioners, sometimes we take ownership of folks' story, which is not our responsibility, and so we have to empower people to take ownership and to share your story without shame, without guilt, because what you're experiencing, someone else either has experienced, they may be experiencing, or they will experience, but your story will give that person hope. And so I think we have to make sure we do that. And I think, one thing we didn't talk about was social media, right? And so many things are shared through social media, they're shared through the news, but who is the narrator of those stories? Sometimes it's not us. Even when we look at like our research books, like who's telling those stories, sometimes it's not us. And so we have to make sure that we are the owner, that we have the penmanship of these stories, and then to celebrate that within our community. And so that kind of connects. The theme is how we're going to celebrate those folks who have decided to share, to dispel some myths. How are we going to celebrate them?
Thank you. Thank you, Dr. Gainey. I appreciate that. Ooh, Dr. Nedra, what you got?
So one of the things I think we can do as a community is to bring individuals together, providers together. And that's one of the things that, I've tried to do since I've actually came to Sentara, is I, develop a consortium where I bring all providers together. Let's talk about the issues. Let's talk about what we can do, from our own company perspective, build out services, share best practices with each other, help each other along the way. We're not big in child and adolescents, but I work with Kempsville, CHKD. Let us come alongside of you, help you build out your services. Then we need to educate. Most people seek services through the ED, through the emergency department. most patients, and the boarding of those mental health patients in the ED has, exacerbated since COVID. So educating those individuals in the emergency department who are taught to take care of emergency, educate them on mental health, give them some mental health first aid, give them the basics, teach them some culture diversity, some cultural acceptance and stuff, and then you take that and stuff, bring in individuals with learned experience to work with individuals so we can get them into services. So you need to bring everybody from the faith-based to, I don't care if you go to the legislature, we all need to come together and tackle this, because it's going to take a whole village. As a matter of fact, it's going to take a village in several countries to fix this. That's how big this is. So if we don't start working together and stop working in silos, we're never going to solve this problem. And I've been in mental health 20-something years, and it has always been a crisis. Nobody ever noticed it until the workforce started getting smaller. People start retiring. COVID came along. You start seeing people, but we need to come together and put our heads together and say, this is what we can do. We're experts in this, like CHAD in kids and stuff. So how can we at Sentara come alongside of you, help you build those services out and stuff? How do we work together to get the patient out of the ED into those services? Yeah. So, breaking down those barriers and sharing, the differences that we have, because, we all in it, for the good of the patient. So how do we come together for the good of the patient and work together and build services in the community? Yeah.
Thank you. Well, Mr. Holloway, you want to take us over the finish line?
Sure. I think my colleagues here have given us a lot of incredible solutions and how we can make a difference in our communities. I would say, if I was to add to that, for me, I think my mind thinks a lot about creative solutions. So Dr. Moncrief-Craig talks about bringing everybody to the table. And so I think about, like, what are some of the ways that we can utilize all of our partners in ways that we don't traditionally think about, so that they can support the system. So for example, like if I gave you, we talked about ED boarding and people needing, getting access to treatment. But what if we had trained our churches as almost like triage centers, where those who are in the church who have the app to be able to support people in need, they can triage the people so that maybe they can be the person that calls them, because we have party lines in churches all the time. So how about, instead of we calling everyone in our church for unhealthy purposes, what if we use you to be a support on a crisis plan so that this person can stay in their community versus needing to go into a higher level of care? Thinking about creative solutions. And then the other thing I would think about, lastly as I close, is truth telling. When we think about practitioners, and I agree with Dr. Fanning that we are called to do this work because we are responsible for each other. And so we will find ourselves in situations where we have to stand alone. And I think when we find ourselves in situations where we have to stand alone, our job and our responsibility is to tell the truth, to speak the truth to power, so that we can dismantle some of the things that create barriers for our people. So we may have to stand up and tell someone that your treatment modality does not serve my community. And so what do we need to do differently so that we can support this person? Because it sounds good on paper, but it's culturally irrelevant to them. And but that takes the courage to stand up because sometimes you have to do that to people who have a certain level of influence. So being able to tell the truth and speak truth to power, I think would make a huge difference in how our communities receive the support that they need.
Did he not take us across the finish line? I saw some. Wow. I just want to say thank you. It is an honor to be in this space with my colleagues, with my daughter, I have to say, my friends. I mean, so much power. And thank you. To the audience who's listening to this, we will post the bios of the persons who've been part of this discussion. And hopefully we can do some different things, some additional things, some creative things, like Mr. Holloway said, to make a difference in our community. Each of us on this call, we work in spaces every day where we see people who are struggling, and it's our people. It's our folks, it's Black and brown communities who are struggling, and we have the power to make a difference. So I thank you, I thank you, I thank you, I thank you. And with that, we will close.